The statements and opinions expressed in this episode are those of Dr. Sigman and his guests, and do not necessarily reflect the views of Veradigm.
It's time to do healthcare smarter. This is Smart Medicine, hosted by Dr. Scott Sigman and powered by Veradigm. All right, CEOs, COOs, and CMOs, lean on in, because today's episode of Smart Medicine is about something that sounds soft and that it hits you right in the balance sheet. I brought in someone who can make that case loud and clear. Dr. Anthony Mazzarelli, the president and co-CEO of Cooper University Healthcare, because he professes something that would make most healthcare administrators do a double take. Are you ready for it? One of the best things that we can do to increase revenue in healthcare is to be more compassionate. And I can already hear some of you going, come on, Scott, how does the soft stuff run a tighter operation? And trust me, Dr. Maz had the same reaction at first until he went digging for the numbers. And he's even got a flashy name for all of this. He calls it Compassionomics. So this episode is for leaders, and honestly, for anyone else in healthcare as well, because the kind of compassion he's talking about benefits us all. And here's the twist. The path to more compassionate care leads us straight to technology. So if you think AI can only make medicine colder and less human, please keep listening, because Dr. Maz is about to challenge that assumption in a big way. Dr. Maz, welcome to Smart Medicine Podcast.
Thanks for having me. It's great to be here.
We're thrilled to have you. So let's get right to it, okay? So obviously you're the consummate overachiever. You've got an MD, you've got a JD, you got a master's in bioethics. Apparently 1 degree was not enough for Dr. Maz. But seriously, what sparked the drive for you to go that deep and broad into your education? And how does having medicine, law, ethics in your toolkit shape the way you lead today?
Sure. So it doesn't mean I'm smarter. It just means I have more student debt than most people. That's the bottom line. But I thought I was going to go into academics. I really was interested in bioethics and that intersection of law and policy and medicine. And my goal was to see patients and teach in a law school and a med school and write papers about policy and ethics. And that's the direction I thought I would go in. And I kind of got pulled into administrative medicine as sort of part of my residency and then as a chief resident. And then I just got more and more involved in administrative medicine and still like to teach and write and do those things, but try to make it all row in the same direction, that the things that I do academically at an academic health system also part of what we do in leadership. And we try to put those two things together.
Yeah, we're going to dive into that because I think the ideas and the concepts that you have are really very unique in healthcare. But early on, you grew up in a family of chiropractors, healthcare providers, medicine, and conversation was at the dinner table. And then you bounce into the ER. Everybody's watching The Pit right now, so we know how crazy it is in the emergency room, right? But really, the truth is things move fast in the emergency room, and the stakes are high too. You're caring for patients, making really important clinical decisions. How have those early experiences really helped to shape your leadership style today?
And I think this goes for any area of clinical medicine for people who become administrators, but at least for me in the emergency department, we make decisions on limited data. And so we have to make a call about what test to order and whether the patient's going to stay or go. And a lot of, I think every branch of medicine has some of those decision points. And that's what you have to do as an administrator. You can never, if you wait for perfect data, you're going to be paralyzed. So I think that's one of the things that I use. And then also to remember why we do it. I mean, at the core of why we do what we do as administrators, we're just a cost center. What we do is support the people who are on the front lines doing our core business, which is seeing patients. It reminds me of that because I still see patients and have had that experience. And as far as my law degree, it's really the deductive reasoning, the how to frame things. I think I lean on it in that direction. And I think about the world a little bit differently because I had that kind of training. I don't think it is a necessity to be an administrator, but it certainly has come in handy.
Yeah, well, obviously what you're doing must be resonating because very early on in your career, they ask you to come on board, the youngest in the system at the time, to become the CMO. And you're delegated with this thing where they say, fix the patient experience and fix physician engagement. That should be a piece of cake, right?
Yeah.
But the truth is those two things can often be at odds. And so you really got to change the culture. So I want you to share with our listeners now the concept and idea of Compassionomics and how it affects what you do on a day-to-day.
Sure. Adrienne Kirby was the name of our CEO, and she gave me that opportunity, and so did our board, to be the chief medical officer. And I was nervous. I had this faculty practice plan of a medical school that was only a few years old at the time, even though we had been a clinical campus for a medical school for 30-some years. And she said, those are the two things you got to do: improve patient experience and improve physician engagement. She said, but don't worry, I'm going to make it a lot easier for you, because I'm going to hire this big fancy consultant. So she hires this consultant, and the consultant gives me this list of things and says, if you can just get the physicians to do these things, then everything will get better. If you get them to do and I looked at that list and I was like, this is not going to work. These are sort of soft, mushy things that I don't know how I'm going to convince a faculty practice plan to do this. And so I went to our number one NIH researcher, the person who everyone knew was the most published, gets the most grants. And I went to him and I said, will you be like the chief main guy for the mushy stuff? And he said, no, I'm a science guy. And I said, yeah, but I need you to science this up. Is there any data behind this? And he said, look, I'll go look, but come on. And so he went and looked, and he was going through a bit of his name's Steve Treziak, and he's the co-author on the books, and he's really the first author. He's the science guy. And he came back and he said, there's some interesting data about this. And he was going through sort of a midlife research crisis at the same time. And then he said, let me look at some more stuff. And then we started looking at things together until we reviewed every single paper in the literature that had to do with compassion and empathy and the connection between doctors and patients and any caregivers and patients, and created a curator of every single one of those studies. And what we found amazed us. It was an incredible message of how strong those things are. And that we knew the only way we could get and change behavior was to drop a big data bomb on physicians that this was the right thing to do, and this would get you better outcomes, it would lower costs, and it would decrease burnout. So we really took, our number one science guy, and then we took the number one RVU producer in the health system, in the outpatient setting, non-proceduralist, number one RVU producer. I made him the other champion because we knew everyone would say, hey, it's going to slow me down and make me less productive. And it doesn't. And so those were the two big champions that we went around the health system trying to get people to think differently about how they interact with patients. And I think that really was really helpful. I think physicians are incredibly good at incorporating data to change their practice. And so that's the approach that we took. And we started publishing on it. And we called it Compassionomics because the study of the economy is economics, or genomics is the study of genes. And this was the study of the connection of compassionate care.
So what I'm hearing is that compassion isn't just a mushy thing, that there's actually science behind it that actually can demonstrate true improvement in clinical outcomes for patients. And we'll talk about that. So when a doctor is sharing compassion and showing compassion to a patient, what's happening in the patient's brain?
And let me give you the disclaimer, right? The number one predictor of clinical excellence, of clinical outcomes, is clinical excellence, right? So you can only make up so much ground, but the power of connecting with patients is immense. It's been shown there's 22 different mechanisms by which, when you connect with patients, they're more compliant with their medication. It's unbelievable, the list of things and the improvement of outcomes that happen when you truly connect with patients. In fact, I'll give you one study. It's a study out of Johns Hopkins. And they asked a group in an HIV clinic, and they asked the patients this one question: does your physician know you as a person? And if the answer was yes, they were 33 higher fold chances that they're on the right medication and 20% higher fold chances that they have no detectable HIV in their blood. It's amazing, the stats that come out. So you can see these studies over and over again about compliance and you look at the impact on burnout, and it's unbelievable what this shows. And here's the thing, we didn't do all this research, right? We were standing on the shoulders of giants. So there's studies in ORs in the 60s that when you had a meaningful interaction between an anesthesiologist and a patient prior to surgery, that the patients ended up needing less opioid pain medicine after the surgery, and that their length of stay went down. And they've repeated those studies in recent years. I mean, that's from the 60s. So what happened was these things each one of these studies were like pebbles, and you would drop them in the water and they'd make little tiny ripples, right? And then those ripples, when we put them together, we see those pebbles and those ripples coming together to make bigger ripples and then ultimately into a wave of data that shows this. But at the time, each of these studies that come out, nice, but no one was sort of connecting them together.
Fascinating. And I'm a huge believer that the human body has an incredible ability to heal itself. And so the idea that compassion and interaction, human interaction, can help in that healing experience, and there's actually data behind it, is awesome. I would argue, and we'll talk about this later, that the patient knowing who the doctor is and how they think and what they're about, I think also would help in that communication. I'm a big physician branding guy, and I'm always talking about messaging. Let your patients know who you are, what you're about, what your messaging and your thoughts are. All right, let's segue now. You're moving on up. You got all these degrees. You did a great job as CMO, and now you're a co-CEO at the hospital as well. So as my guy, Jerry Maguire, would say, now you got to show me the money, right? At the end of the day, hospitals are still businesses. They have profits and losses. They have margins. So I want to know, how is compassion showing up on the balance sheet?
So it's the same metrics, right? We're on the hook as administrators, as leaders, for the bottom line, for the margin, for quality, for patient experience, all those same metrics. It's the methodology to get there. And, the compassion has been shown for all those things. You mentioned malpractice. So it's multifactorial. And malpractice, they've seen this over and over again. We don't fall down with respect to medical care and malpractice because of the medical part of medical care. It's the care part of medical care. Patients make the decision to sue you based on how they think you cared. Two different studies, the Dazon study and the Harvard study. One of them showed, and this is sad, the overwhelming number of malpractice cases have no acts of negligence in them. That's pretty sad. But the other study shows the overwhelming acts of negligence never become malpractice cases. So we know that patients make the decision to sue based on that care portion, not on how well you do in medicine. That's one piece, a small piece. Patients choose who their doctor is. They choose their doctor study after study, not based on where they went to school or the fancy degree on their wall. They choose based on how the things they want and how they communicate. And does their doctor listen? That's how they choose those things. And then we know that hospitals, even when you control for socioeconomics, hospitals that focus on compassion, focus on patients, end up having not only better outcomes, but financially perform better. So it's been shown repeatedly. Now, you asked about burnout. So burnout's a huge financial issue. There's some estimates that it's $500,000 to $1 million for every time you have a turnover of a physician. Why? Well, first of all, you have to ramp them up. And then there's the cost of that turnover of how you bring them in and all the startup costs. And then you lose the institutional knowledge. And then burnout has been shown to be decreased the more physicians connect with patients. And there's an immense amount of ROI there as well. So all of that adds up to what happens at your bottom line. I always tell our people, we're a nonprofit. Most health systems are nonprofits, but that's a tax status, not a business plan. You still have to make money. And so the way to make money has to do with how you treat your people and how your people treat patients and how your leaders treat each other.
We've already hit some big numbers that should make every healthcare leader sit up a little straighter. Dr. Maz clearly stated that physician turnover can cost up to $1 million per physician. So if the well-being of your clinicians and your patients isn't the loudest alarm bell in the room, I'm hoping that number is. And even if you're a nonprofit, Maz put it perfectly. That's just a tax status. It's not a business plan. You still need margins because margins are how you fund better care and get better tools. Which brings us to the big question. How do you actually scale compassion? And how will today's technology enable that? Before we go there, this episode of Smart Medicine is powered by Veradigm. By connecting data, technology, and real-world workflows, Veradigm helps you turn complex information into insights that drive smarter care. Now back to the conversation. Let's go to one of my favorite discussions, which is technology, right?
Love it.
So many people think that AI is going to revolutionize humanity, and then Other people are like, it's the Terminator and Skynet and it's the end of humanity moving forwards, right? And so a lot of clinicians feel like technology has truly maybe diluted their compassion. They're doing more clicks, they're doing more screens, they're not having as much eye contact with the patient. But you've said something very interesting, that technology isn't the enemy of compassion, that it might actually be the answer to propagate. So I want to know, how can both of these things be true? What's your concept and ideal on technology?
Sure, and I do feel they're true. I do think that technology has gotten in the way of connecting with patients, but then I also think the solution is more technology. And also, we tend to blame the EMR and all the clicks and the boxes we have to check as the reason that we've been pulled away from patients. But really, the EMR is reflecting changes that have happened from a regulatory and billing and coding perspective within the insurance industry and the government, our largest insurer over the years. And if we didn't have computers, we'd be on the hook to still write those same things down. It would be just as brutal. But because the EMR came along at the same time as these increased regulatory requirements and billing requirements, we tend to blame like it's the EMR's fault. Like the EMR wants that information, when in reality, we're just capturing information we need to have. So I think the answer is that we can use technology. If we're not going to be able to tame the EMR in that way, and we still need to we're still required to put all this stuff in, the answer is to use technology to help us do what we like to do least, which is write notes. And now you see the rise of ambient technology in writing notes, and it's unbelievable. It's one of the largest, probably aside from the EMR itself, and that was really driven at the institution level, it's been one of the fastest adoptions of technology. If you talk to any CIO or CMIO around the country, which is using an ambient technology to write notes for us. And here's a really interesting point for you, in that I know two different health systems that did a study where they didn't publish it because they were just doing for internal purposes only. And they looked at ambient technology in primary care. And what they found was that the patients had higher experience scores, the physicians had higher engagement scores, but then they found that they saw more patients, which was not the point of using the technology. And they also couldn't figure out how, because they didn't change the physician templates. So how's it the heck? And these two different health systems, I was talking to both CMIOs, and they said they figured out that when they get that phone call where you squeeze in another patient, they have a lower threshold to say yes because they're doing what they love and they're avoiding doing the paperwork. I don't want to see people use that technology to increase productivity. I want to see them use that technology so they can interact with patients more. And I think we're about to enter a golden age of medicine. And I think note writing is just one part of it. But I do think that technology is the answer to some of the technology problems that we have.
Yeah, I know it's interesting because you talk about big AI and little AI. Right now, you're talking about little AI, which is the scribe. And I just want to speak from my own personal experience. I actually use ambient scribing technology, but I also have an actual scribe too. So I'm in a hybrid model, and it's really brought back the joy of me seeing patients in the office. I don't literally hold a computer. I don't even look at a computer unless I'm reviewing MRIs. At the end of the day at 4:00, when I've seen my last patient, all of my notes are done. I'm not bringing charts home to continue doing work. I'm going home to see my family. It has truly reduced the anxiety level that I have, and you're exactly right. I'm more than happy to see a few more patients at the end of the day because it doesn't add any additional labor to the end of my day. So completely agree. Now talk about big AI now too, right? I mean, what's the first thing we do? We go to large language models. I'm trying to figure out what medication some patient's on or what this crazy new diagnosis is. I'm 30 years out of medical school, but we go to these LLMs. How is that affecting medical care in your institution?
Well, the way I think about it, and big AI, little AI, or probably the better way is enterprise AI projects and then empowerment AI projects for those who see patients and those who do work in any kind of either health system or business. And here's what I mean. Big enterprise projects are using AI on revenue cycles so it can do appeals or fill out pre-authorization or all these big enterprise things. We have a great tool called Viz AI where it sits on top of our CAT scanners. And if it sees a bleed in the head that could be a large vessel occlusion where you can do an intervention, it immediately, before the patient even leaves the CAT scanner, it will alert our stroke team and will ascend on top because time is brain. Like those are big projects. Those are enterprise-wide projects. Then there's empowering right at either the point of care, like ambient, or even it's just how to use one of these LLMs to write letters of recommendation or to review things that you do maybe outside of seeing patients, just the little time robbers or administrative tasks of life that you could do better. The interesting part is that empowerment part's important, not just because it makes people more efficient, but it also makes them less likely to push back on the big AI projects. And so there's a study that came out that looked at C-suites, and I think of physician leaders and really physicians almost as executives when you think about how many people are employed in a health system. So C-suites and executives are saving 10 to 20% are saving 10 to 12 hours a week using these tools. Or when you look at people who sit in front of a computer at a desk or on the front lines of organizations, it's less than 5%. And it's because I think that adoption gap is because it takes time to learn how to save time. We have to engage the people that work in our organizations and give them the training to use those tools, not just because we want them to be more efficient, because we want them to feel valued as the world is changing so much, because this technology is going to change everything. We want to feel like we're giving them the tools, and then they also will embrace the bigger projects when they come along, because there's a lot of backlash. I tell people, look, AI isn't coming after your job. It's coming after the parts of your job you don't like if we do this right. Now, eventually, there is a downstream where you do end up realistically probably needing less jobs, but we also have a giant shortage of people to work in almost every job that has to do in the health system. So I think that's the way I think about sort of big or little or enterprise and empowerment, because this technology isn't going anywhere. And so I think in the future, we're only going to need 3 skills. And knowledge isn't one of them, because knowledge will be at our fingertips. We're going to need the ability to use technology. We need the ability to connect with people, and we need the ability to tolerate change, because change is happening so fast. And those are 3 really important skills that our leaders in healthcare need to appreciate, and I think physicians as well.
You got a task ahead of you, because I've been doing this for a long time. And one thing is for sure, physicians are skeptical and they do not like change.
They don't like change, I know, but they like data.
They do like data. Show me the data.
We can show them the data, right? That's the saving grace, right, for us. And also, we're going to be better at what we do. I think we're going to look back at some point and say, because you and I practiced at a time where basically the doctor was as good as what they could fit in their head before they walked in the room.
That's all we did, was memorize things as much as we could. It was a single patient-physician interaction when you're in the room with them. But so I got to ask you, so who are going to be our next physicians? We talk about this all the time. It's not just going to be IQ and your ability to memorize, because this technology is evolving by the minute, right? We're going to have to identify future physicians that are adept at technology and understanding how to use these things on a day-to-day basis. Do you agree?
I agree. And use technology, connect. We still have to connect with people. That's still something that we have to do, because we have to convince them to do these things that, even if it's AI telling us to tell them to do it, right? They have to, and those interactions, those connections, they still drive behavior in an incredible way. And so I still think that's going to be around as well, but things are going to change, and they're going to change fast. I mean, just think about this. In 1950, medical knowledge was known to double every 50 years. The last time they looked at this in 2022, medical knowledge doubles every 73 days. The idea that we're going to fit it in our head is outrageous.
Maz just literally said something that stopped me in my tracks. Medical knowledge doubles every 73 days? Just thinking about the EMRs alone, and now layering AI on top of that? As a practitioner, this seems daunting. According to the World Economic Forum, by 2020, it was estimated that globally, the healthcare sector would generate 2.3 zettabytes of data. I mean, what the heck is a zettabyte? To help you visualize that, we would be talking about 2.3 trillion DVDs of information. And the kicker? It's not slowing down anytime soon. As of last year, McKinsey & Company forecasted that the compound annual growth rate for healthcare data is set to hit 36%. Now, I'm not telling you this to stress you out. I'm telling you this because Maz is right. The data is coming whether we like it or not. And if we want to help patients, we can't treat technology adoption like a someday project, because the wait-and-see approach can quietly turn into falling behind.
The last time they looked at this in 2022, medical knowledge doubles every 73 days. The idea that we're going to fit it in our head is outrageous. And so we're going to have the technology is going to be real-time decision support so we can take better care of patients. And we will. It's going to be fantastic. We will be able to connect with patients, not have to worry about notes, and do what we do better. And I think that's coming. But you have to be able to not only embrace change, but you have to embrace the technology.
We feel your passion and your incredible bullishness on technology, and I am right there with you. Now, we talked about compassion and how it affects patients, but as doctors, we bring a lot to the table, right? We care for our patients. We're the stewards of their stories, of their outcomes, of their potential complications. We absorb the grief when patients have a complication in the care in which we provide. And there's a tremendous sense of responsibility for the well-being of our patients. So in Wonder Drug, you really talk about how compassion isn't just helping the patient, but it's also benefiting the caregiver. So share that with our listeners. I think that's a really important part of the story.
When you focus on other people, whether it's patients, and we physicians have many more opportunities to do this because we take care of patients, but everybody has the opportunity when they interact with other people. When you are more other focused and you do things, it really exploits the difference between empathy and compassion. Empathy hurts. When we feel someone else's emotions, we feel that their pain, it hurts. It lights up the negative pathways in the brain. Compassion is acting on that empathy. It's that authentic desire to help and then taking action. Compassion heals. Compassion feels good. Compassion lights up the reward centers in the brain. And so when you think about endorphins, dopamine, oxytocin, serotonin, those get released when we focus and do things for other people, whether it's patients we're focused on or anybody, we do stuff for other people. Think about the billions of dollars spent in the pharmaceutical industry to artificially increase the amount of each of those things. We can do those by focusing on other people. And we have an advantage in healthcare that we could do with patients, but you have to see it. So the example I give is there was a famous picture during COVID that went around of a nurse in Texas. And he was holding a sign up. And the sign said, "I'm just going to hold his hand for a while. I don't think he has much time left." Talking about the patient, because that was back when family members couldn't be in the room and patients were dying and we didn't know really much of anything. And so I remember seeing that picture and thinking about total despair that lit up only the negative pathways in my brain and thinking, wow, how helpless not only the nurse must have felt, but how awful that is. But there's another way to look at that, which is maybe there's no more important place than that nurse has ever been than holding that person's hand in their final moments. That the opportunity to do that thing that would have been denied by that patient because of his disease, because he can't have any visitors, he was able to fill that spot and see the incredible good he did and the difference he made in that life. Well, that lights up the reward pathways of the brain. So compassion is protective against burnout. Empathy makes you hurt even worse. So you have to see that you're making a difference. And when you think about even defining burnout, it's when you feel like you're no longer making a difference. You have to see that you're making that difference and take advantage of the neuroscience of the situation.
So compassion can scientifically ignite the brain in positive pathways that can help to heal the healer in the moment. I think that's really profound, really great statement. So look, we're getting close to the end. I could talk to you for a few more hours. I love it. You're a fascinating individual and love your passion for all the things that you're doing. But if let's talk about where we're going. So if we could align compassion, business, technology, not as competing forces, but as partners, what do you see healthcare looking like in 10 years? But just sum it up for us in a few minutes here as to where you think we're going to be in 10 years.
Yeah, I think we're going to be in a real-time decision support scenario where you are interacting with the patient and you are being fed information, and whether you're being fed in your ear or in a pair of glasses or maybe a screen that you kind of have one eye on, you're being fed exactly what you need to connect with that patient. Remember that Mr. Jones's wife passed away 6 months ago. You're being fed what the potential differential diagnosis is based on the conversation you're having. You're being fed everything about the patient right as you're talking to them. And that the patient is also interacting with different tools in between those visits to maximize the preventative care they're getting. I really see that we're going to enter this golden age, and the discovery of knowledge in medicine, 73 days is going to feel like nothing. as this technology starts to turn towards science. We always forget about the scientific discovery, and it's going to be incredible, the stuff that we figure out, I think.
Well, sign me up for that. That sounds outstanding. Dr. Maz, we want to thank you for joining us on the Smart Medicine Podcast. Your insights on leadership, compassion, intersection of technology and humanity in medicine are exactly what our profession needs today. We're grateful for your time, your wisdom, and the work that you're doing to help elevate healthcare for both patients and providers.
Thanks for having me.
I love Maz's vision for where this is going. It's technology that puts the right information in front of us to allow us the freedom for more compassionate care with our patients. And that's where this whole idea of Compassionomics really lands. Because if the right tech can strip away the friction and unlock the more human side of things, to me, that's smart medicine. Thanks for listening. If you enjoyed this episode, follow the show so you don't miss what's next. We've got some big conversations coming your way. See you next time.